Thank you. I've been on mute, so we'll start all over. Welcome tonight. This is our first ever webinar. First of all, I want to thank Chris, our community liaison. She has put a lot of work into this. So I thank you for that, Chris. Can someone let me know if you can hear me? This is our first time, so I want to make sure that we can hear you. Do I sound good to everybody? Okay, great. Thanks. Again, we're experimenting with this, and it's been a great, hopefully, asset to our patients and us to be able to reach out to more people outside of Austin who, or even in Austin, trying to avoid MOPAC or 360 or even I-35. Tonight, we're going to talk about new trends in the diagnosis and treatment of prostate cancer. We are really just here to just tell you what we're looking forward to in prostate cancer. It has been a big change in prostate cancer in the last 5 years. And if you were to ask me just 3 or 4 years ago, would I ever be talking about what I'm talking about now, I would say no. So it is an exciting time. First, I'm going to just start off with just some basics on prostate cancer. I really don't want to spend too much time because most of this stuff is online and easy to find, and I'm just regurgitating facts. I think what people really want to know is, what does the doctor think? Where are the thoughts and where are we going today? And that's where I hope to spend a lot of your time, our time together tonight. So just as we go over prostate cancer, it is the second leading cause of cancer in men. It is, besides skin cancer, we see about 300,000 new cases a year. And unfortunately, we have about 30,000 deaths a year from prostate cancer. Now, this number is going down, but it is still a significant amount of men who succumb to prostate cancer, right behind lung cancer. Basically 1 in 6 men, if you are in an office setting or even in my own practice, one of us in our practice will likely get prostate cancer. Fortunately, a majority of the men, over 90%, are found to have localized disease, therefore curable disease at the time of diagnosis. But just shy of 10% are diagnosed when it's already metastatic. So when we talk about prostate cancer, we really talk about it in 5-year chunks. If it is localized, your 5-year survival is over 100%. If it is metastasized, if it has left the prostate to another part of the body, your overall survival at 5 years is just over 30%. And that is actually getting longer with some of the new chemotherapeutic drugs we have to use these days. I'm not going to go over those. This will be focused more on localized prostate cancer tonight. Really, a lot of men go, where is my prostate? Why do I have a prostate? Well, our prostate is right here. It's between the bladder and the urethra. It is why we're able to have children. That's why we have a prostate. It provides the nutrients for the sperm to impregnate the egg in the woman's body. After that, it's a source of sexual pleasure and for urinary control. So when we talk about treatment, typically we talk about whole gland treatment, the entire prostate. Traditional evaluation is a yearly exam. Most men don't like this part. We check the prostate, and then we look at the PSA, which is a blood test for prostate cancer. And there's soft limits. Under 60, we like the PSA below 2.5. Over 60, we're comfortable letting it hedge up to 4. But what's important to know is that about 25% of men with prostate cancer, one I just saw the other day, have normal PSA. This gentleman, fortunately or unfortunately, had a PSA of 1.2, which is very low and considered normal. But he did have an abnormal exam, and that was the reason the prostate biopsy was performed. I want to go over sort of the current best practices, and I want to tell you This has been a lot of controversy in the last 2 years, and there's still a lot of debate on this. And I'll just give you our soft guidelines. So frankly, when do we need to start checking for prostate cancer? Rarely before 40. If you have a family history or if you're African American, you get it once a year starting at 40. That is non-debatable. No one argues that. So family history, dad or brother, or if you have significant uncles and grandfather, I consider that a significant family history. You start at 40 once a year. You get the blood test and the prostate check. If you don't have a family history, if you're not African American, typically, traditionally, we start at 50. However, the new recommendation is really going towards 55. This is debatable. I believe that men should check it once in their 40s, once in the 50s. Then, if it is normal, they can start at 55, going once a year or once every other year. And then we usually check this until age 75. And then after that, we really don't, have a strong recommendation. And that's really where the doctor and patient discussion comes into play. Since I have many healthy 80-year-olds who fortunately have good genes and take care of themselves and will likely live into their 90s. And these gentlemen, I still believe it's prudent to check their PSAs. I have some people who are unhealthy in their 60s where I don't feel that a PSA is absolutely necessary to check because unfortunately their overall health, their 10-year survival is quite low. So when we look at PSA screening, it really says to stop at 75, but again, I think that's quite up to the patient's health and between the doctor and the patient. Really, I want to spread a little light on this, showing the debate. This just came out earlier this year on just showing that really PSA screening does save lives, but when does it save lives? Does it save it in that first 5 years? No. First 10? Probably. First 13? Absolutely. So that's where getting that PSA once a year, once every other year, we're probably going to be okay and not miss any big event that we would have miss an opportunity to cure the disease. So really, who is at risk of prostate cancer? The biggest, like I said, is family history or African American race. And then if that PSA is above 1 in their 40s, that's something that we really would monitor a little closely. In their 40s, it should be below 1, 1.5. So that's something that it's really a soft, again, level, but it's something that we pay a lot of attention to. So really the bottom line is screening is an important part, but really when I think the argument on prostate cancer is not screening, there is some downside risk to biopsies, but there's really no long-term morbidity or side effects from biopsy. But what I've always believed is, we need to take biopsy very seriously, but at the same time, it never hurts to know about the cancer. And I think the focus of the discussion is really on how aggressive do we need to treat the cancer, not how aggressive we need to find the cancer. So diagnosis in my brain does not equal treatment. And so just because we find cancer doesn't mean we always have to treat it. And that's where I think the debate now is really leaning towards, and where technology has really helped us get more comfortable with this idea. And so traditionally a biopsy is performed through the rectum in the office under a local anesthetic. It takes about 15 to 20 minutes. There is some discomfort, I will not lie. Most men do not want to do it the next day. But at the end of the day, mostly it's not as bad as they imagine. Much like a vasectomy, not nearly as bad as they imagine. So, can we do better than our current standards? Our current standard is a finger test, a blood test, and then an ultrasound. And then unfortunately, if we find cancer, just looking at it and taking a picture of it, then using that information to decide how do we treat it. And today, fortunately, I think we can, and we are doing much better than what we were doing just 3-4 years ago. So really our stance at the urology team in the last 2 years has been look before you touch. And what we mean by look is not using the prostate exam or the ultrasound, but using something much bigger and better. And that's really where the game changer in prostate cancer has gone. And that's been the multi-parametric MRI of the prostate. That is a prostate MRI. And that's really been the problem with prostate cancer traditionally. We've never had a good way to look at the cancer. And what I mean is ultrasound, CAT scan, we can see the outside formation of the prostate and be able to draw a nice architectural exterior photo. But we really couldn't trust what's going on in the interior of the prostate. And even MRI wasn't a good modality until recently. And it was only until recently as the magnet strength of the MRI has doubled and computer technology have we been able to really, with good amount of confidence, look at the interior of the prostate. And here what I show is just the phases of MRI, and I won't get into the technical details, but here's just a standard MRI, and you can see that the prostate is sort of a patchwork of colors, white and black and a white band here, and we didn't really know what that meant. But then with technology, we can look at really how these cells move, and are they diffuse, are they thick? And when they don't move, they sort of light up in this picture. And then in another frame, we see that there's no movement again, and this is more concerning for cancer. So we use all three to really see if this is something that's normal or something suspicious for cancer. Again, this is a normal prostate. Beautiful. This is what most men want. You have a normal small prostate in the middle. The urethra is right here. Cancer is usually on its outer surface in the bullhorn, as I call it. That's it typically, but a lot of cancers we're finding in men are up in this area called the transitional zone. Again, a prostate, big, this is BPH, but here the peripheral zone where the tumor is, and unfortunately for this gentleman, this is a big tumor extending outside the capsule. This we would never know by biopsy. This is a game changer for this gentleman because this tells us that radiation typically would not be as effective as surgery. And unfortunately, this person would likely need surgery and radiation given this disease. And we can counsel that patient before we ever even do a biopsy, not knowing that cancer, but having a high suspicion. So this again, we're looking, the MRI measures cell movement, and it's looking at restricted diffusion. The less movement between particles, the more likely that it is cancer. Again, I'm just going to run through some images. This is one where we see increased signal. Again, that's suspicious. These are very similar to what you saw. And the restrictions or limitations of MRI is that it can be fooled. One is it can miss cancer, and Gleason 6 is considered low-grade cancer. That's a cancer that looks a lot like normal tissue, and the MRI will miss that. We know it will miss it 50% of the time. 50% or more, the MRI will not pick up Gleason 6. But Gleason 6 is traditionally not a tumor we treat. It also, because the technology is new, protocols are young and not mature yet. We do have good data, but still we don't have a nice protocol that you can do an MRI in any city and any radiologist can read that. Luckily here in Austin, we have great radiology colleagues, 3 who are especially trained in this, who have been just a great resource to our patients, and really have been why we've been able to be as successful with the MRIs we have in the last year and a half. And also inflammation. Men who've had prostatitis in the past, which is very common, I call it the male UTI, that can fool the MRI as well. And a lot of times when we do a biopsy where there's high suspicion, if there's not cancer there, it's almost always inflammation. And these, again, when we look at MRI, it's not just one picture. We look at 3 different pictures, and they all have to match up to sort of give us a sense that this is cancer and not something else. And so what we're moving towards is, instead of a standard templated or random biopsy, more of a targeted biopsy. And most of our patients here who have a biopsy usually have an MRI beforehand. The times we don't get an MRI is one when a person has very bulky or palpable disease. Another time is when the PSA is excessively high, where we'd be doing other imaging to look if this disease has already spread. But with men, a majority of the men when they present have normal exams, have slightly elevated PSAs. Prior to just doing a random biopsy, we get an MRI to really look at, is there a concern? And if there is, we can really aim in on that target. And that's a machine that we've invested in here, and we're very excited about it. We've been using it as a demo, and now have invested in this machine to bring to our patients, and that's called the Urinav system. We'll be the only one here in Central Texas. Actually, I think one of two in the state of Texas. I'm not certain. Don't quote me on that. But this is just exciting. I cannot tell you how excited I am about this, because it really allows us to pinpoint where the tumor is and give a diagnosis of meaning to the patient. When we look at random biopsies, what I've always considered a random biopsy is we may miss some tumor. So if a person is diagnosed with prostate cancer, we know that that random biopsy is sort of the ground floor. That's as good as that cancer is going to get. If we were to remove the prostate, we know about 50% of those men, 50 to 40, will be upstage, meaning when we take out the whole prostate, that we'll find more cancer than there actually is. And that's unfortunate, because it could have changed our treatment if we knew that before. Now, with the focused biopsy, we have to be cautious that we are heavily saturating an area of abnormality. So we may overcall a tumor, meaning that we're getting more aggressive disease in that one area, but if we were to blend it with the rest of the prostate, it may be a lesser overall tumor grade. So when we do a focused biopsy, I consider that the ceiling. That's as bad as it could get. And if we took out the prostate, maybe with the rest of the gland, it may not be as bad as it actually is. And so that's something we always have to keep in mind when we are talking about treatment options. And basically, this technology is a technology that uses the MRI with the help of the radiologist to zero in on the tumor, and then it lines it up with our ultrasound in real time, and it gives us a target. So this is a patient we did not so long ago, and what you do is see the target here, this red area, and here's another patient, and you see the needle going through it, so we can actually see the needle going into the tumor. And what's also neat about this is if that patient unfortunately is diagnosed with cancer, if we elect to follow them and need further biopsies in the future to see if that tumor is changing, we can pull up the old map and re-biopsy that same area. So it gives us a lot of precision and really gives us a lot of ways to account for that patient. And here's a patient of mine, one of the first we did. This is a gentleman who already had a negative biopsy by another doctor. We had gotten an MRI because his PSA was rising, and we wanted to see if we were missing something. And we did see an area of abnormality. And you can see number 1 through 10, or 1 through 9, or 8 was just a templated biopsy. That was a standard biopsy, 1 through 8. And there was an area of abnormality in number 9 and number 10. You can see on number 9 there was inflammation, so that's the one thing that the MRI can overcome. And then on number 10, though, you see, unfortunately, that there was some cancer. But fortunately, it was low-grade, low-volume cancer in one area. This gentleman is currently on active surveillance. We're watching him currently with every 6-month PSAs, and once a year we'll do some kind of surveillance, likely an MRI in the next year. And so when we look at the diagnosis of cancer, we typically give it a grade, and that's called a Gleason score. And a Gleason score is really a pathologic diagnosis, meaning that when the pathologist takes the tumor out, they look at it under the microscope, and that's the Gleason score. The problem with the Gleason score is that it's just a picture, and it's antiquated. It's from the 1970s, and it really revolutionized prostate cancer because it provided a standard. We can send that pathology around the country and have 10 different pathologists read it, and it will come back. 10 pathologists will come with the same read. But the Gleason score doesn't always tell the story, and unfortunately, we can't always rely on it. And now with genetics and biomarkers, we're able to really further define or split hairs in the type of cancer people have. So when gentlemen who have Gleason 6, it's something that's low grade that we typically watch, but sometimes that can act more aggressive. Patients with Gleason 7, which is an intermediate grade, where that's sometimes the hardest grade because that's where a lot of therapies will be good. Surgery, radiation, HIFU, cryotherapy, and even some you can watch. In Gleason 8, 9, and 10, those are bad actors. That's high-grade cancer. I don't really think further pathology helps in that case. Those are tumors that we have to sort of hit hard, whether it be surgery followed by radiation, or chemotherapy followed by surgery. These are aggressive type tumors. One of the tests we've been using in the last 2 years is by Myriad Genetics called the Polaris score. This is a genetic test looking at cell aggressiveness. We are looking, this is not a real patient, this is just an example, but this is a patient who had a Gleason 7, and we're really figuring out how aggressive the tumor is. And what we see is that it acts less aggressive. I'm going to blow this up a little bit. Less aggressive and more like a Gleason 6. And that if really the name of the game is mortality. What's his mortality in 10 years? And, you know, so we look at it about 6%. And so you take a guy who's 69, he'd be 79. Unfortunately, his mortality just at baseline is higher than that. And so this is a gentleman with a low volume cancer, low grade cancer, who would probably do well with radiation, someone you could watch given his age. I don't think surgery would maybe be in his best interest. It may be over treatment, too aggressive. So this is a guy that he has elected active surveillance with the knowledge that he will likely need radiation at some point in his life. So one of the other tests, and I unfortunately don't have a slide, is a new test that we've been using for post-prostatectomy. And this is a test that really looks at genes, over 1,000 genes they take, but they take the whole prostate and it look at what is the risk of metastasis. And this is called the Cycle test. And I'm really excited about this test. It really will tell us, because men, as I showed you on that one slide on that MRI where that tumor is bulging outside the prostate, traditionally that man will need surgery and radiation. But the question is, does he really need radiation? And so with this new genomic testing, we might spare men again from excessive treatment. And so this is a newer test that we're just starting to utilize in some patients, not all patients, but again is a helpful tool in really further defining that patient's cancer and really personalizing prostate cancer. So sort of to sum everything up, I think what's really been the game changer in prostate cancer is now that we can see it. We're catching up. We have really never had a modality to see prostate cancer like we've been able to see breast cancer or colon cancer or kidney cancer or liver cancer. Now we're catching up, and now we can really focus those biopsies just as we've been able to with breast cancer, and how we've been able to with kidney cancer and liver cancer, and really give those patients a very accurate diagnosis to them. And then I think the future will show, do we need to really treat the whole prostate? And right now we're doing targeted therapy, men who have one area of cancer, but the rest or 90% of their prostate is normal? What if we just ablate that tumor? And we've been doing this, but what I've sort of termed this is interactive surveillance. You know, we've traditionally had an all or none approach with prostate cancer, meaning that we either don't treat at all, or we treat the whole prostate. And we've always had these two diverse ways of prostate cancer. And now I think that the MRI, we could comfortably start talking about, do we need to treat the whole prostate? What if we treat that one area? We're still on the hook because we know it may come back somewhere else in the prostate. But I still have my prostate. I'm not going to leak. Maybe I won't be impotent. I won't have bowel or bladder problems. You know, and I can minimize the side effects. And that's really the name of the game, is trying to maximize outcomes and minimize side effects. And that's where I think we're moving towards, is really not only targeted biopsy, what we're currently doing right now, and also targeted therapy, which we're currently doing right now in a limited fashion. But this is where I think we're going to be in the next 3 years. So when a gentleman comes to me in 3 years, it won't be because their PSA is elevated. The primary doctor will already have checked the PSA, reconfirm that it's elevated, and likely the patient would have an MRI, and that MRI is concerning. And that's when I think we'll see him. So I think the standard of care is shifting from a old traditional way to a newer technology that's radiation-free as far as imaging is concerned, and very precise and very reliable. But it is still in its infancy. It's something that I'm very excited about, and obviously we've invested in as far as getting the latest technology to provide to our patients here in office. And finally, what I always tell you, there's no silver bullet for prostate cancer. That's what we're looking for. There's no pill, no surgery, no radiation or chemotherapy that will say, hey, 100% cure, no casualties, no side effects, do this and you'll be done with it. That's what we're looking for. That's what the hope is, and I'm very excited about that. Now I'm going to open up this presentation. I'm going to do a few questions, and also want to run a little poll just to see how you guys like this. Just to find out who we have in the audience. You know, if you wouldn't mind taking some time. So it looks like a large percentage are people just for information or know somebody who has prostate cancer. Real quick, how did you hear about this? We posted flyers and emails, and it was on Facebook. I don't Facebook, Twitter. I do sparingly. We want to find our most efficient communication with you and not bother you too much, and hopefully it's helpful. And it looks like Chris's emails have been great. So thank you, Chris. So are there any questions y'all have? I want to try to open this up.
All attendees are muted and may unmute themselves by pressing *6.
So you can either ask by unmuting yourself, or any questions you have, you could just type in the bottom. And I put that, I'm going to put one more just to see how you guys like it. Thanks. Good. Helpful. I hope you find it helpful. And best ever. That must have been my wife. I think she's watching. So a question I got was the cost of MRI as a first-line diagnosis, and they are not inexpensive by any stretch. Again, if money was not an option, I would get an MRI on everybody. On average, they run about $1,500 to $1,800. That's the insurer contracted rate. If a patient is not insured or has is not covered, they run about $1,000. And this is a cost that the patient has to determine if it's of value to them. But that is definitely something we always talk about. I know I make many phone calls a week to insurers. Fortunately, a lot of the times they are covered, but sometimes they're not. But to put it in perspective, a prostate biopsy on average, once you include the pathology cost, which is the biggest cost, runs about $2,500 to $3,000. And generally, if a patient does have prostate cancer, an MRI will be obtained. So from an insurance standpoint, sometimes the MRIs are a cost saving because if the MRI is negative, that patient may not need a biopsy. That's not always the case, but that is something that we sort of discuss. So the MRI, another question is how's it done? The MRI is done on a table. They used to be small tubes that you walk into. Now the newer MRIs are almost like a CAT scan, a big donut. We used to have to put a balloon in one's bottom, which was very uncomfortable to sit for 45 minutes still. But now with the new speed of MRI and stronger magnet, we no longer need anything in the bottom. They take about 25 to 30 minutes depending on the patient size and the size of the gland. But frankly, for most patients, it's a non-event these days. It used to be a somewhat uncomfortable exam, but with the stronger magnet and newer speed, they're quite fast. So another gentleman just asked about Medicare coverage on MRIs. Fortunately, Medicare, we're having a lot more success with Medicare coverage, so that has not been a problem. 2 years ago, it was very difficult to obtain a MRI on patients' Medicare. The other gentleman asked about, unfortunately, recurrent tumor. This is unfortunately a difficult situation for a lot of men and something I deal with daily. As you may see, is the patient had a radical prostatectomy in 2009. Unfortunately, it came back in 2013. Not sure if it was a positive margin or very aggressive disease such as a Gleason 8 or 9, even if margins were negative. Then they underwent radiation therapy earlier this year, and the PSA is slowly rising, still less than 0.5, it's 0.336. When do you consider hormone therapy? This is again, there's some variables I don't know about. The aggressive of tumor, have you had any imaging? Did that show any tumor? Likely not. It's probably a negative scan after that prostate, and so they did a standard template radiation. Depending on how fast the PSA is rising and the overall patient's health, you really, sort of have that discussion with the patient and androgen deprivation. therapy, because that has its own side effects. Osteoporosis can increase risk for insulin resistance or diabetes, um, heart disease if prolonged. So when we talk about hormone therapy, in my brain, it's something to seriously consider. It has its benefits and definitely it has its negatives. And this is a big debate right now. A lot of research is going in this exact question. A small study, not published, done at MD Anderson, there is some hope, show that men who've had a radical and who had radiation, their mortality rate, their death rate from prostate cancer was almost zero. And so it doesn't mean they don't need therapy, but the mortality rate was quite low, almost zero. This was a very small study. It was only presented at a conference. So I say that with some hesitancy, but I think it just provides a lot of hope. And also with new drugs, Provenge, Zytiga, Xarelto, Zytiga, these are all new drugs that just came online in the last 3 years that have been a tremendous help to a lot of our patients. So another final question I see is, can MRI or other techniques identify distant prostate tissue? And again, this is again something that I'm very excited about. Currently not available to my understanding. There's something called a choline PET CT scan, so choline PET scan. Recent studies showed the use of this binder found microscopic disease, 2 millimeters to 5 millimeters of disease in lymph nodes. This was done at Mayo Clinic and Memorial Sloan Kettering. We do not have the availability to do this test in Austin or in Texas, even at MD Anderson that I'm aware of. I just had a patient I sent down there to see if they did this test. It's still under investigation by the FDA. The results look awesome. It really tells the extent of microscopic disease. And this would be something to utilize in guys with high-risk disease prior to doing surgery. Because if we're found to have microscopic distant nets, that disease, unfortunately, is no longer curable. So would we want to put someone through surgery or even radiation when we know that the disease is already spread? So that's called a choline PET CT. And I've tried to order 3 of them in the last month, but I've unfortunately been unsuccessful to getting it done here in Texas. Any other questions? Well, I'm going to stay online for a few more minutes. If you guys want to stay on or ask questions, feel free. But I thank you for your time. Hope to do these more frequently about different topics. I hope you found this of value. Please let us know through our website. Chris is our community liaison. We appreciate your feedback, even technical things. I can't understand you, Dr. Giesler. You're too dark, too light, make the picture bigger. Unfortunately, I can't. That I'm aware of. We're still learning. So thank you, and we appreciate all positive and constructive criticism. But I hope you found this of value, and I hope this helps you and your loved one. So a question we just got was on the technology of metal pellets placed in the prostate to guide radiation. These are called fiducial markers or gold seeds. And frankly, we have been doing a lot of these at the request of our radiologist, radiation oncologist. Fortunately, radiation therapy has really progressed in the last several years. The machines here in Austin are really top of the line, and because of that, they got a lot of precision. So the radiation oncologists have requested that prior to starting radiation, we place seeds in the prostate, which will help the computer to further better line up the radiation, hopefully limiting side effects of the radiation to surrounding tissue organs. And this has almost become a standard, especially with our patients who are on CyberKnife, which is a form of radiation, and even on our traditional radiation. This is a procedure that literally takes 3 minutes in the office and provides a lot of value to our patients. Another one was on diet and anti-inflammation. I am a big believer in environmental factors influencing cancer, and environment, I mean, as well as diet. That's the biggest environmental thing we expose our body to. There's a lot of science on inflammation with heart disease, linked with colon cancer. We also know with bladder cancer, and even chronic prostatitis, people have increased risk for prostate cancer, so inflammation. I also believe that once a patient is diagnosed, the tumor feeds off certain things, and many of those are sugars. I've had several patients ask me, what can I do to slow this cancer down if they're on active surveillance? And I've told them, frankly, to be a nutritarian or a high nutrient-rich diet with limited or no meat and limited or no carbohydrates, which is almost impossible. But high fruits, vegetables, and one patient who I just saw 6 weeks ago, who is now 3 years out from diagnosis with a PSA initially above 4, I think it's 4.6, took that to heart and has become a vegetarian with limited carbohydrates, and his PSA is now 0.96. He's had one MRI. We have not done another biopsy. The MRI was negative, and we are watching him, knowing that we'll probably do a biopsy here in the next year just to make sure we're not missing anything. Side effects of radiation. Well, I won't tell you I'm the best person to talk to. I usually defer to my radiation oncologist, since I'd rather my patients hear it from the horse's mouth. But in general, I think what the things you don't need to worry about with radiation is incontinence or urinary leakage. I think the things that we see with radiation periodically are worsening flow problems because the prostate swells, or worsening bladder problems because the bladder is irritated and they go more frequently. We do not see as much as rectal issues such as diarrhea or bleeding. We do see it periodically. These are typically short-lived. That's less and less these days. Acutely also, men don't have any erectile dysfunction, but they know in 2 years they will see some diminished, if not complete, erectile dysfunction. So even though the erections don't take a hit, acutely it does happen over the course of time. As someone said, prostate health is heart healthy, and that is a line I use all the time. Another question is why I like to wait patients after prostatectomy, after their catheter's been removed, to wait about a week. I don't mind them doing some gentle exercises, but generally there's a lot of edema and swelling, and the exercise regime could be quite uncomfortable for patients. Even though a lot of them do it, I do hear that frequently that they're quite sore, and so I tell them a week off won't hurt them and may only help them from a pain perspective. Another question on alkalization of blood. This is become in vogue lately, using diet or baking soda. I think my great-grandmother used to do this for certain disease states. I warn people against this. I think it could be very dangerous if not monitored. I am not the nutrition expert. I like to read about it, but I won't tell you that I'm the expert. There is some data showing that alkalization of low alkaline water um, uh, can be assistance. I don't prescribe it or recommend it to any of my patients. I just think the potential danger of it is not worth the benefit, which is marginal at best. So I'm going to end this meeting. I just want to thank everyone again. Y'all have a great evening, and I look forward to doing this again soon. Thank y'all.